Thank you very much, Dr. Amanoff, and to everyone who's helped in arranging this, which would include Aaron, Ariane, and all the volunteers today. And thank all of you for coming and spending your Saturday, beautiful Saturday here. I have a lot to accomplish, so I'm going to try to tell you where we're going, and we'll zip along here. But I'm going to first talk about an overview of Parkinson's disease to get everyone up to speed, talk about the current treatments, and some very interesting data about current treatments from something called the PD Med study that just came out recently. Quickly talk on neuroprotection, and just a few sentences about exercise for Parkinson's disease, because there's a new study regarding that. And then a new approved treatment for Parkinson's disease patients, actually for one particular symptom of Parkinson's disease, and a few treatments that have gotten to the stage where the FDA is at a level where they may be reviewing those treatments for approval, and then treatments under development. So lots to talk about, and we'll get rolling real quick here. So here's your quick medical school tutorial in Parkinson's disease. It's common. It affects 1% of those who are under 65 and under, and 5% of those who are older than 85. So common, and becomes more common as with aging. It has major movement symptoms or motor symptoms that include tremor, slowness, stiffness, and a variety of gait and postural changes. And then the great treatment intervention was appreciated in the very late 1960s when levodopa was found to be useful, and then after that, dopamine agonists were useful for many of these motor symptoms. But it's not a homogeneous, uniform disease, as Dr. Tanner introduced. It has remarkable variability. 25% of people don't have tremor, and a good number of patients show only subtle progression over time. The classic autopsy findings are the loss of dopamine-releasing neurons and of Lewy bodies microscopically. And then this just shows you a normal autopsy where a section of the brainstem called the midbrain shows normal substantia nigra, or black area, right here. But in someone with Parkinson's disease, you don't see, or you see a depleted area of black strip, which corresponds to the loss of dopamine-releasing neurons if you look at it microscopically. Now this has consequences upstream, or higher up in the brain, and that's what this scan shows here. So the dopamine neurons that live in the substantia nigra project upwards to an area that we call the striatum up here. And if you use certain tracers, you can see evidence for those healthy axon terminals because they concentrate and store dopamine, and that's what's done here. So this is a fluorodopa scan, and you can see nice bright areas here, which corresponds to the successful storage and of dopamine and fluorodopa. In someone with Parkinson's disease, there's a loss of those nigra bodies, or some of them, and therefore there's a loss of the terminals going up to the striatum, and that's what's seen in this patient with Parkinson's disease, where you don't see this rich concentration of the tracer in this lower area of the striatum on both sides. But you can predict that this person is a little asymmetric with worse symptoms on the other side of the body because there's a more severe loss on this side. So now I'm going to quickly cover all Parkinson's disease medications in 2 slides, and then we'll move on. But I'm going to divide the world into non-levodopa or levodopa-sparing treatments on this slide, and to levodopa treatments on the next slide. So we'll go class by class here, and the first class that I've selected is monoamine oxidase inhibitors. There are 2. They come in more than 2 forms, but 2 main drugs here, which is selegiline and rasagiline. Both have a very mild, or rather mild symptomatic effect, and both have been raised as possible disease slowers. But the results, the studies that have been done looking at both agents don't provide conclusive or unambiguous results. And so it remains an open question whether there is a disease-slowing property to these medications. Dopamine agonists are the second group here, and that includes pramipexole, ropinirole, and the rotigotine 24-hour patch. The pramipexole versions that used to be at least 3 times a day medications now have a once-a-day form that may be useful for some people. Amantadine is a medication that was developed for treatment of the flu, and it turns out to have useful benefits for tremor control in patients with Parkinson's disease, and for those who develop dyskinesias, can often be helpful as well for that problem. Trihexyphenidyl and other anticholinergics are sometimes used for treatment of tremor and for cramps. On we go to the second slide here. So levodopa-type medications or hamburger helper medications for levodopa are covered in this slide. So levodopa and carbidopa is commonly used in America. The carbidopa part everybody wants to know about because it doesn't seem to be what we talk about in these lectures, but it is a decarboxylase inhibitor. It prevents the breakdown of levodopa. If you didn't give a person the carbidopa part, the levodopa would probably not cause much benefit, and it might cause more side effects than benefit. So you need that as part of your treatment. So there's the immediate release versions of these that just are known as levodopa carbidopa, and then there's a slower release version or controlled release version or a long-acting version or an extended life version. So lots of different initials. If your carbidopa levodopa has initials after it, it's probably a slow-release version. And this, this form in general has a slower onset of benefit because it's more gradually released, but it can offer benefits that last a bit longer because it is more gradually released. Over the years, strategies have been developed to boost the benefit of an individual dose of levodopa and to extend the duration of the benefit. And these have come in the forms of other medications that inhibit the breakdown. And those examples of these are entacapone and tolcapone. They are COMT inhibitors, or catechol O-methyltransferase inhibitors, and they slow the breakdown of levodopa in the blood, allowing it to last longer and to deliver more levodopa to the brain. And there is a combination pill that includes entacapone and Stalevo available. So now that you've been fully exposed to all the medications for Parkinson's disease, I'm going to take it to the macroscopic and microscopic research.
I'm going to try to yell and take it through this. This is a slide showing the midbrain where the dopaminergic neurons live and projections north up to the striatum here. And then we move on here to slightly more microscopic. So again, the dopaminergic neurons here going upwards. The blood vessels that carry the levodopa that's been absorbed.
Oh boy! All right, I really got to balance out here. So the levodopa has been absorbed, and we're relying on these two medications to prevent it from being broken down before it actually gets to the brain. So carbidopa is the main player here in the United States. In Europe, it's finasteride. Some people can also boost this by also taking entacapone or tolcapone. So levodopa, because it's neutral, can penetrate across the blood-brain barrier. It's now available to be changed by the dopamine-releasing terminals from levodopa to dopamine. And so that's how dopamine usually works, or levodopa usually works. There are other, and the impact is on these medium spiny neurons. Blowing this up a little bit further, here we go on this slide. Again, the yellow part here is the medium spiny neuron, and this is the dopamine releasing neuron that you see here. This is where dopamine will be released, and these are the dopamine receptors. Dopamine agonists bypass all of this part, and they can directly pass from the blood into the brain, and they can act directly on these dopamine receptors. There are other inputs coming into these medium spiny neurons that then transfer normal activity of the brain forward through the medium spiny neurons. And these include the cholinergic fibers, and there are different receptors for these. This is where trihexyphenidyl works. And then there is a glutamatergic or excitatory pathway through which amantadine can have its benefit or effect. Now, because levodopa has only a limited half-life in the blood, it is not surprising that we see fluctuations in the benefit of medications. And we often call these motor fluctuations, or the effect that it has in motor fluctuations, or wearing off when the benefit of the medication is waning. Some people also have peak dose dyskinesias, which can be a wiggly or jerking movements of limbs that is different from tremor. And we think that this often corresponds to peaks in the amount of levodopa in the person's blood. And this cartoon sort of tries to convey that a person takes a dose of levodopa, then there is an increase in the blood level with a period of time during which there's enough levodopa available to get normal neurotransmission going, but that's only lasting for a certain period of time, after which we would have wearing off. Now, many people thinking about Parkinson's disease and noting complications of the disease as time goes on have wondered whether our treatment is part of the problem. I have some good news here. I think it's not usually the big part of the problem here, and I have evidence to share it with you coming forward here. So, but just to articulate some of these concerns, some people have wondered, is levodopa responsible for the early onset of motor fluctuations? Or does tolerance develop? Is it true that levodopa only lasts 5 years, for example? Some people have wondered, does levodopa somehow have a toxicity of its own? Does it cause a more rapid disease progression? And I think all of these concerns together, magnified through the internet and chat rooms and things like this, has also caused a levodopa phobia out there. So the PD Med study was a very interesting study, has a lot of novel features, and was conducted in the UK, mainly, with 2 other sites in Europe. And it was an open-label, randomized study of treatment effects of levodopa, dopamine agonists, and MAO-IVs. So patients would come in, they'd be evaluated, they'd say, do you want to be in the study? And they would call a central clearinghouse, and the clearinghouse would randomize people to one of those 3 treatments with a fairly, under a complex regimen. They were able to recruit 1,600 subjects to one of these 3 treatments, and then they followed these patients for variable periods of time. And so the median duration of follow-up was 3 years, with a range up to 9 years. And the outcomes were different than what we normally see in Parkinson's disease studies. They used the PDQ-39, which is a patient outcome, kind of reporting their experience of Parkinson's disease mainly. And they used also a shorter version of other outcome forms called the Hoehn-Yahr form. And so now to graphs. Let's take this over. So this is looking at the percentage of patients stopping treatment over time. So kind of a different outcome, but kind of interesting here. So patients were randomized to 3 treatments, but the treatment could be stopped at any time according to what the doctor saw and what the patient was reporting. And other medicines could be added on. But this just shows you what medicines patients kept on during the course of the study. And it shows that many people who were initially randomized to MAO-IVs, 72% stopped it over the course of 7 years. And those who were randomized to treatment with a dopamine agonist, 50% stopped it. But levodopa offered the most enduring benefit and was tolerated over time for many patients. Back over here. So this is a graph showing mobility. What you see over here is the red group is those treated with levodopa, and the blue group treated with levodopa-sparing medication. So that would be monoamine oxidase inhibitors or dopamine agonists. And what you see is that low scores are better. So what you see over time is that there was a slight, subtle advantage to people who were randomized to levodopa compared to those who were treated with a dopamine agonist or monoamine oxidase inhibitor. So the great news and the other observation here is that the people initially randomized to levodopa are not getting worse over time compared to those randomized to the levodopa-sparing treatments. They're staying right along the same track. In fact, always just a tiny bit better. Now, some people will say, well, yeah, but, are they getting tolerant? Are the doses of levodopa being increased? And so this graph attempts to answer that question. So they have to calculate something called levodopa equivalence, because dopamine agonists, there's no levodopa in that, and you want to be able to compare the amount of medication the patients are taking. And so it's possible to look at ropinirole or Mirapex and to give rough estimates of how much levodopa that medication is like. And so they do that. And if you, at the initial 1 year's time point, people who were randomized to levodopa compared to the other two groups were taking a little bit more. But if you follow the line, over time there is a gradual increase in the amount of levodopa equivalent doses that all the patients in all three groups are taking. You don't see the levodopa group going up higher and higher and higher. In fact, over time, over the course of this study, the levodopa equivalents became higher in the other two groups that people were randomized to. Now, one thing is known, probably because levodopa has fairly sharp pharmacokinetics. I showed you that cartoon of rapidly rising levels. Dyskinesias do occur, and they occur earlier. And this slide shows that occurring. So dyskinesia rates show up, or dyskinesias show up in a percentage of patients even in the first 3 years here. As time goes on, though, in patients randomized to the other two groups, the rate of dyskinesia does not remain zero, but it begins to rise as well. Because these patients, their disease is progressing, and some of them are taking more medications, and they're developing dyskinesias too. And what you begin to see is not that the Parkinson, those randomized to levodopa go higher and higher and higher, diverging away from those randomized to the other treatments. You see that they actually begin to converge. So, and I think very reassuring here is that 7 years out, the amount of dyskinesia is not above 50%. Okay, so conclusions from this study, there can be many, but some of the main conclusions are that in those randomized to levodopa, there was slightly better quality of life, slightly improved activities of daily living, and improved mobility outcomes, despite the slightly higher rates of dyskinesias. There did not appear to be any cumulative adverse effects of early levodopa treatment, and no evidence that early levodopa leads to worse long-term outcomes. And a really interesting finding is that treatment with MAOIBs seem to have almost as much benefit, or as much benefit, as randomization to dopamine agonists. So a lot of very interesting conclusions and observations coming from this study. We're going to shift gears and we're going to kind of wrap up neuroprotection in Parkinson's disease. Dr. Tanner did introduce this concept, needless to say, we're very much interested in any therapy that might slow the progression of Parkinson's disease. And there are a number of strategies being looked at, including physical therapy, medical treatments, dietary supplements, and prescribed medications. This is a list of things we've tried, and we've really tried, and that are negative. So CoQ10, there was a hint that it might slow the progression. A much bigger study was done, and the answer from that, just published this year, is no. Creatine was a very large study, 1,700 patients studied for up to 5 years or more, did not show benefit. Small studies of minocycline and GPI 1485, a growth factor, did not show benefit. And pioglitazone was recently shown not to offer clear benefit. Dr. Tanner also mentioned that we're just starting a study called STEADY, looking at a calcium channel blocker, and we're recruiting patients with very early Parkinson's disease to help answer that question. To help Erica have some momentum, and before the break, maybe you'll do some poses or maybe some aerobic exercise. I want to remind you that a study conducted 2 years ago did show benefit with Tai Chi. Patients were randomized to 3 groups, Tai Chi, resistance training, or stretching. They did an hour session twice a week and were followed for 24 weeks, or half a year. And they found that the Tai Chi group improved more in stability and turning, and the Tai Chi and resistant groups had fewer falls. And we're not talking just a few fewer falls. This chart shows the number. So in those randomized to stretching, there were 186 falls. In those randomized to resistance, there were 133 falls. And in those randomized to Tai Chi, only 62. So a really significant reduction there. And if you can imagine that each fall could be a bad fall, this is a fairly striking result. So switching to brand new data, we're getting there. The U.S. Department of Health and Human Services recommends 150 minutes of aerobic exercise per week. And some people in the room may say, well, that's a lot. It's about 1.5% of your week. So maybe you have time for this. So a study was done looking at other effects of aerobic activity besides just heart outcomes. And they looked at a 6-month aerobic training program to see whether it had an effect on thinking. And they did find, and they compared it to a stretching program, and they found an improvement in normal elderly patients, normal elderly people. So, this kind of approach was adopted by a very practical neurologist whose name is overwritten here, but Uck, who's in Kansas City, in Iowa, and he recruited 50 to 80-year-old people with mild to moderate Parkinson's disease who weren't active. So I'm not talking to those in the room who are active, but I'm talking to those who aren't. And they started with a 3 times a week sessions near the home, starting at 15-minute walks and increasing up to 45-minute walks 3 times a week over a 6 weeks period. And the goal was to increase heart rate to 70 to 80% of maximum, or the best effort that could be done without developing an uncomfortable or unsafe walking. And they made adjustments for those on beta blockers. And people wore a fitness bracelet that could collect heart rate information, and they could follow that as part of the study. Just to give you a sense of what heart rates we're talking about, for men who are 65, it would be 116 beats per minute, and for women, it would be about 101. They tried to compare continuous training and interval training and group sessions because they thought those things might be better, but they weren't practical in Iowa because people couldn't meet during the winter very well, and so there was dropout due to that phenomena. And so what they could really do was look at individual continuous training, which means you in your neighborhood, you in your mall, you somewhere nearby that you don't have to drive somewhere to get to. And the mean walking speed was 2.8 miles per hour, not terribly fast, but not sort of looking in windows and stores. Okay. And they were able to look at 49 people, and a variety of improvements occurred. I was struck. Improvements in aerobic fitness, not surprising. Walking speed, not too surprising. But these are things that we really struggle to help people with Parkinson's disease. They found benefits to cognition, particularly the executive dysfunction, fatigue, quality of life, and mood. So some very practical information about how aerobic exercise could be useful for people with Parkinson's disease. I'm going to talk briefly about the new approved medication that is directed at one of these autonomic symptoms that often occur in Parkinson's disease. It's about lightheadedness when standing, which is sometimes due to a drop in blood pressure that occurs upon standing, which is not so uncommon in Parkinson's disease. And a number of medications can cause this: blood pressure medications, prostate medications, dopamine agonists, but also the MAOIVs can cause postural hypotension. If eliminating any one of these medications is not successful, because lightheadedness can be subtle and transient, but sometimes it's not so subtle, and a person actually faints, and that's a bad thing. I think I can assure you with. But so if eliminating agents that could be causal don't help, then use of midodrine and fludrocortisone could be used. If these aren't effective, suddenly we have a new approved medication called droxidopa that might provide benefits along these lines. I'm transitioning, since we just had the one newly approved medication, to medications that have gotten to phase 3 status and may now and may be undergoing FDA approval in the near future. One of these is one that I mentioned a year and a half ago when we met, which is this extended release capsule, which is going to be called Rytary if it's approved. A phase 3 study showed that the formulation reduced off time by an average of an hour or more per day, and FDA review is expected in January. There are other people trying to look at levodopa delivery and improved levodopa delivery, and one of those is an Israeli group called Neuroderm that's developing a pump that will actively bypass the GI tract and deliver levodopa through the skin. And a phase 2 study showed reduction of motor fluctuations and off time. And it's not a huge patch. I think years ago, if we talked about a levodopa patch, we were talking about something that would cover up most of your back. So this is getting a little more practical in size. And then another strategy being developed is an inhaled form for people who have abrupt wearing off and need to get back, turn back on, and they're working on an inhaled version of levodopa. This is to remind me that some people see things that may not be there, and this is a cartoon, or actually an image drawn by a patient who's showing us what they see sometimes. And hallucinations and paranoid feelings are not uncommon in Parkinson's disease, and it's probably a combination of Parkinson's disease plus the medications. We often will reduce medications that might be causing the hallucinations, such as anticholinergics, selegiline, amantadine, or dopamine agonists. And if hallucinations remain problematic, then we can then we have to use other approaches, which is usually adding a medication. And traditionally, we've used medications like quetiapine or clozapine. These medications are antipsychotic medications, but if there is memory impairment, cholinesterase inhibitors can be quite helpful too. This new agent called pimavanserin has recently been studied and got to the phase 3 level. and showed greater reductions in hallucinations and paranoid behaviors in patients randomized to it versus placebo. They were allowed to continue all the other medications that they were taking for hallucinations. And so this is an encouraging study and might provide tools that perhaps with fewer side effects for people who do have these problems because they can be very disruptive. I want to talk about stem cells because we always get asked about it. And I want to try to approach it head on here. So there are no recently published studies on this approach in humans. I mean, there's a lot of work in laboratory animals, but in humans and Parkinson's disease, no recent studies. There are real theoretical limitations on getting an even distribution or release of dopamine by putting in big cells into an area. You can only get so much spread of the cells through our typical strategies of surgical injection of these cells. So there are concerns that this approach may cause hotspots or areas where there's a lot of dopamine released or not much at all. And you might get problems or dyskinesias just due to that phenomena. And that kind of problem was seen in the fetal cell transplants that were done a number of years ago. There probably will be new studies going on in the coming year, but they'll be at the phase 1 level. Other studies to know about going on in Parkinson's disease, there is a study of infused glial cell line-derived neurotrophic factor going on in England. It's fairly exciting. It involves the placement of a reservoir and a pump to deliver this neurotrophic factor. But this is getting back to the idea that maybe growth factors will be useful in reducing the breakdown or reducing the loss of dopaminergic neurons and maybe somehow resuscitating them. And then there was a very interesting study of a vaccine developed to remove alpha-synuclein, and that vaccine, that very small study, was considered safe and well tolerated, with evidence that there was an effect of the vaccine to develop antibodies against synuclein. We have no idea whether it has any benefit at all in people with Parkinson's disease, and so more studies are going to be going on with that. Gene therapy continues at the phase 1, phase 2 levels, and there are a number of studies that have already been performed and some that are ongoing. There are a number of gene therapies being used. One is looking at an enzyme that helps patients with Parkinson's disease be better converters of levodopa into dopamine. That's one that we've been involved in. There's another study looking at GDNF as delivered as a gene therapy, not as an infusion. That's going on at the NIH. So I want to conclude with these remarks that neuroprotective treatments are being researched. We don't have a winner yet, but we're looking for them. Aerobic exercise appears to improve cognitive function and reduce fatigue, so I really encourage you guys during your break and maybe later in the day or tomorrow, doing some aerobic activity. You can start very short activities and then extend that to up to 15 minutes 3 times a week. The PD-MET study shows that the benefits of levodopa are maintained over time. New preparations for levodopa are being developed. And I think the concerns that can develop into a levodopa phobia are misplaced. Droxidopa is now approved and is a tool for people with postural hypotension that doesn't respond to typical agents, and that other treatments, including new levodopa preparations, a vaccine against synuclein, and gene therapies are being looked at. Thank you very much.